Hey everybody, Dr. Rafage from Vet Triage. We are continuing through this issue of Veterinary Surgery from November 2024. We are talking canine again. Case report. There we go. Use of an autologous pericardial patch to repair a post-traumatic caudal vena cava cicatrix in a dog. So autologous means that it's coming from the donor is also the recipient of a piece of tissue. Pericardial is the sac around the heart. Cicatrix is scar tissue. A study comes out of the UK. The goal is to report the use of a pericardial patch graft to repair a post-traumatic caudal vena cava cicatrix in a dog. 1-year-old Rottweiler. Kinking of the caudal vena cava and resultant Budd-Chiari-like syndrome was diagnosed from echocardiography as well as computed tomographic angiography. Budd-Chiari-like syndrome is not the same thing as Chiari malformation or Chiari-like malformation, which is a caudal, occipital, calvarial malformation affecting dogs and resulting in secondary cerebellar herniation, syringohydromyelia formation, and so forth. Budd-Chiari is different. It's abdominal. It's a hepatic disease. So surgical exploration via the right 6th intercostal thoracotomy was performed. Release of the cicatrix was unsuccessful in reducing the pressure gradient, and a pericardial patch graft repair of the thoracic caudal vena cava was therefore performed to relieve the obstruction. The results found 6 weeks post-op showed resolution of the ascites, which is abdominal fluid formation, and all clinical signs. 24 months, dog was normal. Conclusion was a pericardial patch graft technique can be used successfully to reconstruct the thoracic caudal vena cava in cases of traumatic kinking where this dissection of the fibrotic band, which is the cicatrix, alone fails to reduce caudal vena cava pressure. So again, these case reports are good for a summary of the prior literature and for learning about new techniques that can be used for your surgical boards. Otherwise, this is not really a statistical analysis. Introduction. In humans, obstruction of venous flow from the liver to the right atrium is termed Budd-Chiari syndrome. The hallmarks of Budd-Chiari syndrome are abdominal discomfort, a modified transitate ascites, and hepatomegaly. Obstruction of the caudal vena cava is uncommon in dogs. It could be congenital or acquired. Kinking of the caudal vena cava following vehicular-related trauma has been reported. A study hypothesized that when the thorax is struck from the left side, the vena cava bends and stretches, exacerbated by the heart rotating on the pericardial ligament, and the diaphragm displaces caudally, disrupting the normal vessel architecture, leading to fibrosis and adhesion, which causes partial obstruction of the caudal vena cava and Budd-Chiari syndrome. Successful treatment via surgical excision of fibrous tissue and resection and anastomosis of the caudal vena cava has been reported. Repair with patch grafts involving autologous tissues such as pericardium, diaphragm and peritoneum, and gallbladder, as well as xenografts and synthetic grafts have all been reported. So the materials and methods: blunt trauma to the thorax occurred while on a walk. The dog developed abdominal distension, lethargy, and appetence, ascites. Thoracic radiographs found normal cardiac silhouette but multiple rib fractures that were healing. Clinical findings and investigations found echocardiography showed a normal cardiac structure and function. There was suspected narrowing of the caudal vena cava close to its insertion on the right atrium, and there was turbulent blood flow identified on color Doppler originating from this narrow portion. They treated the dog with diuretics, so furosemide, and performed a computed tomographic angiography which revealed kinking of the caudal vena cava immediately caudal to the heart base along with multiple left-sided rib fractures. So treatment was surgery, routine right 6th intercostal thoracotomy, revealing an abnormal caudal vena cava. The pressure in the cava was 11 millimeters of mercury compared to the cranial caval pressure at 5 millimeters of mercury, so a pressure gradient of 6 millimeters of mercury. The phrenic nerve was found to be discontinuous. There was dissection through dissection of the scar tissue. The vena cava became straighter, but with the release of the cicatrix, the pressure remained unchanged. So they placed a Statinsky vascular clamp For a 2-minute trial partial occlusion, the edge of the pericardium was sutured to the dorsal edge of the caudal vena cava incision. The epicardial surface of the pericardial patch was positioned to face the caval lumen. Caudal vena cava pressure measured 7 millimeters of mercury, and the cranial vena cava pressure was 5 millimeters of mercury. They placed a 12-gauge, 30-centimeter thoracostomy tube at the 8th intercostal space. And so the images you're seeing here, this is a three-dimensional reconstruction of CT scan of the kinked caudal vena cava, where the arrow is, and then the next one is a surgery that shows the kinked caudal vena cava here, and this continuous phrenic nerve right there. And then these are more intraoperative images showing the patch. Results found visualization of the previously narrowed portion of the caudal vena cava was challenging. However, no turbulent flow was identified on color Doppler. The caudal vena cava remained dilated, and there was no evidence of peritoneal effusion, and ultrasound examination of the hepatic veins was unremarkable. Discussion. Repair had previously been suggested as a potential solution for caudal vena cava narrowing secondary to pericardial rupture. Treatment via surgical excision of the fibrous tissue and resection anastomosis of the caudal vena cava has been reported. More recently, intravascular techniques to relieve obstruction have been described, and then also intravascular stents. Potential stent complications include stent fracture, stent migration, reocclusion, misplacement, thrombosis, and these are documented in humans as well. Balloon dilatation was attempted in one cat with caudal vena cava obstruction, but this failed, and they placed a stent. Intravascular balloon dilation and or stents are attractive because of low morbidity in the short term, but the technique relies on a permanent implant or implants. Excision of the cicatrix alone did not achieve a reduction in caudal vena cava pressure, and a procedure to directly expand the lumen of the vessel was therefore indicated. A successful reduction in the caudal caval pressure was achieved with an autologous pericardial patch graft. Patch grafts from other autologous tissues like the diaphragm or xenografts or synthetic implants could have been considered. Autologous pericardial patch graft techniques have been described in a variety of cardiac surgical conditions in dogs. And typically the smooth mesothelial cell-covered parietal surface, which is considered to be less thrombogenic, is positioned facing the heart chamber or vessel lumen. Autologous pericardial patch grafts were patent and exhibited a smooth endothelial lining with no evidence of contraction at 15 months following surgery, whereas both xenografts and synthetic grafts showed severe deformation and contraction that compromised the lumen. Pericardial patch grafts are a familiar technique, and if performed with temporary partial vascular occlusion for large vessel reconstruction or temporary venous inflow occlusion for cardiac surgery, do not require specialist equipment, unlike intravascular techniques or open heart surgery under cardiopulmonary bypass. An experimental study which showed minimal adverse sequela to unilateral phrenic nerve resection in dogs, you would need to have a fluoroscopic study to diagnose unilateral diaphragm paralysis, but this was not required in this case because of lack of clinical signs. They chose to give aspirin and clopidogrel for 4 weeks to this dog after surgery, because 4 weeks is the time period that would be covered in a smooth endothelial layer, and thus the risk of thrombosis formation will be reduced. Evidence for antiplatelet therapy in dogs undergoing vascular surgery is sparse, but a 4-week duration of treatment has been described for dogs undergoing mitral valve repair and a single dog undergoing excision of a congenital obstruction of the caudal vena cava. The ideal duration of antiplatelet therapy in dogs undergoing vascular surgery, and indeed whether it is required at all, remains unknown. Finally, it is important to accurately diagnose the cause of Budd-Chiari syndrome to have an appropriate treatment plan. Congenital causes include cardiac defects like chortria, atrium dexter, and membranous obstruction of the caudal vena cava. Acquired causes include tumor-related invasion or compression of the vena cava, right atrial disease resulting in right heart failure, hepatic fibrosis, caval syndrome with heartworm disease, and stenosis secondary to trauma, like the dog described here. The pathogenesis of traumatic kinking of the caudal vena cava and resultant Budd-Chiari syndrome involves left-sided thoracic trauma. It is hypothesized that the caudal vena cava bends and stretches, the heart rotates around the pericardial ligament, and the diaphragm displaces caudally, causing disruption of the normal vessel architecture, fibrosis and adhesions, which causes partial obstruction of the caudal vena cava. In this case, the antecedent trauma, multiple rib fractures, and the presence of the intact pericardium correlate well with this hypothesis. So just a cool case report and a good study for surgical residents. Thanks for watching the video, and we'll see you again in the next one. Take care.